I thought we'd, thanks for coming in person. I think I prefer it. Seems like it's going the other way now. Hopefully we'll have Henrik Bauer, who's with me from Karolinska, coming to give some comments and help with the talk tonight. He's a very well-known professor of sarcoma surgery, and he's got some valuable insights. So I believe the talks are interactive, and I hope this one will be as well. We're going to go through basically introduction to sarcoma surgery. That's one part. We'll go through some x-rays to try and stimulate some conversation about the things we've spoken about, and get you describing an x-ray, because that's definitely part of your asking. And then if we've got time, we'll just quickly go through some radiotherapy and chemotherapy. When spotting for your exams, in terms of sarcomas, I would base a benign question on GCT, a malignant question on osteosarcoma, and then I know a little bit about soft tissue sarcomas, although traditionally they're part of general surgery in South Africa. They're managed by orthopedic surgeons elsewhere in the world. And then metastatic disease is a big topic. And then some basic science like denosumab is very topical at the moment. Bisphosphonates, you should know from yes. And then lastly, oncology, radiotherapy, chemotherapy. I wouldn't go into learning all the drugs and what regimens there are, but what I would learn is side effects, early and late, and how that affects you as an orthopedic surgeon. Mainly your anesthetic and work up on the patient. Okay, and I'll try and go through this fairly quickly because I'm sure a lot of you know it already. But sarcomas come in many forms. Okay, who knows why is it called a sarcoma? What's the difference between a sarcoma and a carcinoma?
One comes from connective tissue, like a sarcoma. One comes from like
epithelial tissue. And what are the differences between them? Differences in spread.
Blood spread, lymphatic spread.
Yeah. And what are the differences in local behavior?
Carcinoma is infiltrating the quite aggressive members. Sarcomas, so like you can actually push soft tissues, of course.
And what's the difference in the histology? Carcinomas are pretty uniform, bland, homogeneous. Sarcomas are heterogeneous, both in their histology, X-ray appearance, behavior, etc. So, yeah, think about that when you're answering, because you can see from these slides they occur all over different parts of the body. They come in different shapes and sizes. And they're aggressive. But they are rare, thankfully. Only about 1 or 2% of all cancers that we know of are sarcomas. But they occur in young patients. So they form a large part of cancer in teenagers and young adults. Okay. Most of the time, they're idiopathic. We don't know why they come. That would be your most common question, and I guarantee you asked by a patient who has a sarcoma. Why do I have a sarcoma? We don't. 95% idiopathic. 2.5% roughly we caused by chemo and radiotherapy. 2.5% part of a familial syndrome like Lee-Fraumeni. Okay. And we all know, basically, if you're not sure where a sarcoma arises, it's going to arise around the knee, hip, or shoulder. A few things like a Ewing's will arise from flat bones like ribs, scapula, and pelvis. But if you're unsure, go for around the knee. Survival used to be dismal. Well, it depends where your reference point is, it's still pretty dismal, but it was before the advent of chemotherapy, it was about 20% at 5 years. Now it's about 60 to 70%. That's got nothing to do with surgery, it's all to do with the chemo. Because about 80% of your patients, when they present to you, will have micrometastatic disease. The chemo is there to mop up that disease, hit it on its head. 20%, so you can learn 80 and 20, 20% will have macrometastatic disease. How do they grow? As described, they grow centrifugally, so they go from the center outwards. They have a pseudocapsule, they respect fascial boundaries. Okay. And remember, when talking about compartments, when you look at Hinikin classification, bone is a compartment. So it arises within the bone in the medulla, and when it breaks through, that means it's extra compartmental. Okay. You need to know skip versus satellite metastases. Yopi, what's the difference between those two?
So skip lesions are, so satellite lesions are the one close to, I think it's to the proximity of your primary tumor. So skip lesions are further away, so if you're around the knee. The skip lesion you'll find proximal femur, so higher up in the same bone, whereas satellite lesions are much closer and surrounding.
You would like the Earth, a satellite, and the Moon. The Moon would be a skip, satellite would be a satellite. And the next picture shows us that. Joint involvement, despite occurring around the knee, is quite rare. However, they're aggressive tumors, they grow very fast, they double in size every 28 days. So they can cross the knee. They can cross the knee in the multiple ways. They can go around the knee, they can go through the knee, through the cruciates, they can break into the knee. They can, of course, spread through the blood supply and cause skip metastases. So, as you said, blood is the most common way they spread. That's why they go to the lungs first. That's why we do chest x-rays, that's why we do CT chests, and we look in the periphery of the lung. Because they get into the blood supply, they get to the lung, they get filtered out, and there's in capillaries. And then other solid organs. So a lot of the time in our workup, we'll do a CT chest of the lung, and we'll include the upper abdomen because we're looking at the liver and the spleen. Staging system, you should know Inikin. I don't really think you should know anything else. They're all very similar, some different in different ways. Okay. I'm not going to go through this too much because basically it's very obvious. When preparing, I wouldn't worry too much about your latent diseases. Those really don't do much. It's the active and aggressive that you need to watch out. Imaging. You all know imaging. I think the only things we haven't mentioned is bone scans. So we do a technetium 99 bone scan to look for bony mets. Okay. CT chest abdomen. Okay. So that's part of your workup, which you do before doing anything to the patient. Okay. Because if you do your MRI after your biopsy, it's going to cloud the image. You're going to have changes from your biopsy tract, and you're not going to be able to interpret that information as well. This was most especially during the time when they used to do open biopsies. Now we do needle biopsies. It's not such a problem. An MDT is something that you may not be familiar with. It stands for Multidisciplinary Team Meeting, and it's pretty much the gold standard now. We have one here at Ski, we've got them in private, and the point of that is to meet with the oncologists, pathologists, radiologists, everyone involved in the team in treating the patient, so that you get because there's so much gray area here about how to treat these patients, you get a consensus, and it has been shown to fewer reoperations, better quality of initial surgery, and better quality of overall survival. So a patient will present in many ways. Usually the story is that because it's a musculoskeletal problem, they'll present with some sort of vague pain, usually around the knee or hip or thigh. They'll attribute it to a fall or an accident, sporting injury. They go to a physio, chiropractor, therapist, all sorts of things, okay, until it gets to a size where they can feel it. And unfortunately, because they are deep structures, they rise from deep structures, they present, and they have a very rapid aggressive doubling time. They present quite in an advanced state. They may have been treated for another condition. They may have an attempted surgery, which is called a Whip's procedure, when you think, and this is most common in soft tissue sarcomas, when you think it's a lipoma, so you're going to cut it out and it ends up being a synovial sarcoma or a liposarcoma. Constitutional symptoms are actually fairly uncommon, although you should know them. They come about 25% of the cases, and they are more in advanced or aggressive tumors. Okay, pathological fractures 10% of the time. Again, they convey a poor prognosis, mainly because they are a more aggressive variant of that disease. Okay. Generally, we say that they spread via the blood to the lungs, solid organs, but some of them, some soft tissue sarcomas can spread to the lymphatics, and there's that mnemonic CARES at the end, which stands for clear cell sarcoma, alveolar soft part sarcoma, rhabdomyosarcoma. You don't need our epithelioid sarcoma and synovial sarcoma. So look for lymph nodes in those conditions. Workup is very basic, and when you give your workup in the exam, just rattle off a whole bunch of blood tests. Okay, have a reason for doing it. Most of the time, it's to see how well or sick your patient is. Okay, how long they've had it for. For example, you want to know what their HP is because you're going to take them for a biopsy. They're going to have an anesthetic. You want to know what their UNE is for the same reason. Some of the oncology markers like LDH, there's another one, ALP, markers of bone turnover, they give you an idea about how aggressive the lesion is, and there's some prognostic value attributed to them, but I don't do them as routine initial blood markers. Again, I don't monitor them for you. Inflammatory markers, you can do those, but usually this is very obvious. Okay, it's only in those ones where you're not sure if this is a benign condition, usually benign conditions. Is it active or is it aggressive? And sometimes inflammatory markers can help you there. And then we discussed some of the other. Biopsy. Who here has done a biopsy for the sarcoma? Just one of you? Okay. What was your plan going into the biopsy, Mike?
So did the MRI before, so that we could see what's the best tract. Obviously, the plan is to incorporate the biopsy into your definitive field. So plan what your overall surgery will be, and you want the biopsy on the longitudinal axis of that. And so that's what we did. We did it around the knee for that distal femur child. We used the Jamshidi, which gives you better yield than a fine needle. So the fine needle is not really used anymore. And the plan was to just get into the center of the lesion, not just the periphery of the lesion.
That's mostly right. The center, what's the problem about the center of the lesion?
Is necrosis often in the center.
Yeah, so sometimes you can just get necrosis back, and that's not very useful to the pathologist.
Yeah. So in this one we took 3 or 4 cores just to see if we could get a more representative field.
Was it Henry Manking in Boston, who was one of the godfathers of orthopedic oncology? He said that, but you can let the resident do the final surgery, make sure that it's a consultant who does the biopsy.
Yeah. Very true words. I think planning of the biopsy, we see all sorts of stuff. Transverse incisions, okay. Biopsies on the wrong side of the leg. All those things are important. So the first thing is really just refer the patient if you can. If you can't, you're in a rural area, you have to do the biopsy. Chat to someone before if you're unsure. Okay. And then the Jamshidi is the way to go now. I think open biopsy is really only if you failed in a needle biopsy, which occurs around 7% of the time. according to UK stats. Okay. The gauge of the biopsy is important because the pathologists need architecture. They want to see bone. They want to see what the cells around the bone are doing. They want to see matrix. Okay, they don't really, it's not like a carcinoma where a few cells sprayed onto a slide will do. Okay, so they need to see that architecture. That's why the Jamshidi should be about a 14 gauge. We'll get some matrix. Okay. And then when you do the biopsy, try to get a representative lesion. That's why the MDT is important, because you can chat to your radiologist and you can say, what part of this lesion looks active? You go for that rather than another part that doesn't. And in a lot of first world countries, in fact, the radiologists do all the biopsies either ultrasound guided or CT guided. So they do it via the needle. And then lastly, I think, especially if you're unsure, you should send all your biopsies away for culture, because you never know, it might be an infection. So this is, I'll just briefly run through how we do it. So obviously we square drape most of the time. We make sure that you're biopsying the right leg. Make sure you know where you want to biopsy, make a mark there. Just make a little nick in the skin with the 15 blade to get the needle through. You put the needle through. That is a Jamshidi needle, which is graduated, so you know how far you can go, and you can measure that on the MRI scan. You remove the stylet and stick a syringe on the end. You go into the needle with the syringe, negative pressure. You get a sample, which you then squirt onto, that's my way of doing it, you squirt onto an ABD so that invariably you'll get blood, and that goes away. And then if it projects, you can't see my mouse, but you should get a nice core of bone to project well with the light. Let's skip this tonight because we don't have a lot of time, but basically this is what osteosarcoma will look like. The main thing here is pink, lace-like osteoid, immature bone. Okay, that is how you differentiate. That's, if you get that and you ask you this, it's osteosarcoma. You should be able to recognize that this is collagen. Okay, so it's, you saw on the other slide a lot of cells. This slide, not so many cells. This is cartilage in between. Lastly, this is, what is this, Yogi?
Spindle cell?
Sure.
Huh?
Yeah, so that like what the helicopter fibers not fibers.
So if you see all these wavy, you hear Chinese letters, alphabetsu, helicopter, or styrofoam pattern, helicopter in a wheat field, all this jazz. But I promise you, for your OSCE, in order to basically calm yourself down and get you into one box, so you just need to see lace-like pink osteoid, cartilage, or fibrous tissue. They're not going to show you anything else. Okay.
Sorry, on the right, there are lots of blue cells. That's not what I mean.
No, and apology, it's just the picture that I got.
Oh, okay.
So that's what you're talking about is?
Small round blue cells. There's a diff, but Ewing's doesn't look like that. So
also, these are a bit more spindle shaped, as Michael said. They're not quite as round as you would get in a Ewing.
I think I've heard that to me.
Yeah, I think there'll be something obvious. Okay, bad news. Treatment. Okay, you should know the pathway of a sarcoma patient, which is presentation, diagnosis, neoadjuvant chemotherapy, surgery, and adjuvant chemotherapy. What's a sarcoma? Bone sarcoma gets radiotherapy. Hell, I've told you, I've told you this in many talks. You've all been here before. What's the main treatment for a bone sarcoma?
So it's normally chemotherapy.
What's the main treatment for a soft tissue sarcoma?
It's radiotherapy.
Okay. But there are some exceptions.
So what goes radio?
Ewing's is very, very radio sensitive. Usually it gets all three treatments. It gets chemo, radiation, and surgery. Okay. Most of the time, we're able to save our patients' legs. 90% of the time. The function they have afterwards, we can have a debate about that afterwards, but nowadays amputation is unusual, except I think in our setting where we present late for many reasons. What do we want? We want early stability, we want early post-operative mobilization in most cases. Neoadjuvant, we won't get into the complexities there. The main aim for neoadjuvant chemotherapy is to mop up the micrometastatic disease, to assist surgery in a sense of creating a line for helping with margins, for trying to downgrade the size of the tumor in some circumstances. If it's very near a vessel, maybe the chemotherapy makes it a bit smaller or stops it from growing. And that helps, it may facilitate surgery. And then it helps with the prognostic value. How does it do that? GG. Anyone want to help him?
Right, so your aim is 90% necrosis on repeat
What's
MRI gives you a better prognostic.
Repeat MRI?
Pre-operatively, so following a neoadjuvant.
But
Chemo.
MRI scan, very poor indicator of response to chemotherapy. So there's no validation there. What's the grading system called?
There's the peaky and there's the huvos. Peaky is the percentage, so 90 to 99 is excellent, 89 to 90 is good, and then I know less than 70 is poor. And then the
Osteosarcoma, yeah, not for you.
No. And the huvos one is the percentage of normal tissue to abnormal tissue. Now I don't know details.
I've learned huvos, and I keep it simple that above 90 is a good prognosis, below 90 is a poor prognosis. Below 90, it doesn't matter if you get 70 or 20, you can't say which one is going to afford you a better prognosis. And that's on histology. So when you've cut the tumor out, you send it to the pathologist. And again, that's a little bit of an estimation. Well, it is here. I don't know. Is it?
Absolutely, yeah.
So they look at it literally.
It's not a science.
It's about 80% necrosis. So monitoring while on chemotherapy, we often use a tape measure to monitor the size of the lesion to see whether it's growing or not. Sometimes that'll influence how many cycles you give. Usually for an osteosarcoma, it'll be between 3 and 5 cycles. Okay. And we repeat the MRI scan if you have that service available. If you're giving chemo and you're worried that this thing is getting bigger, so maybe you can intervene earlier. To decide that you can do that. But usually we will want, as Kirsty said, a repeat MRI after chemotherapy because things have changed, okay, in the time that you've been giving the chemotherapy, and you want to plan your surgery based on that MRI. And you need it between 4 and 6 weeks because when you stop chemotherapy, it doesn't mean that the whole tumor is dead. So what is alive can continue growing and change potentially your surgical plan.
I think in osteosarcoma, many oncologists feel that the tumor has to shrink. Whereas in osteosarcoma, since it's a bone tumor, when it stops growing, it mineralizes. So it will not shrink, but it will be much harder, and the patient, I think a very good sign is actually that the patient doesn't have pain anymore. And usually the pain should go away after 1, at most 2 cycles of chemotherapy. And if you do an MRI, you won't see any difference, but if you do a normal radiograph, you'll see that it's become much more mineralized and well-defined compared to the pre-chemo.
Absolutely. And our recent case of the distal femur proximal tibia came from Namibia. Oncologists were disappointed that this tumor had not decreased in size with chemotherapy, so they gave some radiotherapy. So unfortunately, that sentiment isn't well known, but it's very true, and especially with pathological fractures. So if your patient sometimes presents with a pathological fracture, that's a first presentation of an osteosarcoma. Put them in bed, put them on traction, give them chemo, the fracture unites and makes surgery much easier than if you try to operate on it with a broken. And this talk's not about surgery, but just to say there are many different ways to skin a cat here, range, and you should know the gambit, okay? And different places do different things according to what they have available. Here we are more prosthetic based with a megaprosthesis or endoprosthesis. And that is proximal femur, distal femur, proximal tibia, a combination of both. Other places use a lot more allograft, which will be fresh, frozen, not the radiated stuff that we have. And then you can use it with a prosthesis, an allograft prosthetic composite. Or you can use autograft, which can be prepared in different ways. You can pasteurize it, which means you put it in an autoclave. You can irradiate it, which means you blast it with 60 gray or 100, I can't remember actually. Do you remember how much it is?
I think 60 gray.
Yeah, I think it's 60. Yeah. So you you do the operation, you take half the pelvis out, you put it in a bag, send it to the oncology department, they give it blast it with radio in one fraction, give it back to you, put it in the patient, attach it with plated screws. Or you can freeze it. This was a question on one of the exam with liquid nitrogen. So you put in liquid nitrogen for 20 minutes, you take it out for 20 minutes, let it thaw, put it back into the patient. So just a few reminders, rather refer, if you have that ability, remember the MDT. Okay. Our knowledge of, general public's knowledge of sarcomas is very poor, not like breast cancer, prostate cancer, or thyroid cancer. So, and that's the knowledge in the community as well as in the medical field, and so what procedures happen. The basic premise is to resect and reconstruct in surgery, and take as much time in your reconstruction as you've taken in your resection, basically. It doesn't make a lot of sense to spend hours taking out this tumor and then quickly shocking in a prosthesis which gets infected or dislocates. Okay, this is basic. I think we will just skip this because I want to get onto some cases and some oncology. But these are some options you can go through. The talk is available, get it from one of the guys who's access. Vascularized fibula is a workhorse in which type of patients? You've seen one in the clinic, Michael.
Yeah, he was young and healthy, he had an osteosarcoma to be resected.
Yeah, so a lot of the time in a young patient where we don't want to put a big piece of metal in for obvious reasons, they're still growing, so you try to preserve the growth plate where you can. You want a biological fixation because I think there's a 1.7% year-on-year increase in your chance of revision from when you've had it. So if you put it on in the 12-year-old, they're going to need more and more surgeries. It's going to become more and more difficult with more and more increase in your chance of infection. So biological is always better in the younger patient. This is some fancy stuff that when we have time for, we can discuss with cutting jigs and 3D printed prostheses. Maybe I'll just touch on this. All active, aggressive, benign conditions. How do you treat those? That's on the slide. In case you haven't read it. Someone from the back.
You curatize them.
Yeah, how do you do that?
I actually haven't seen one, but it's an intralesional curettage. And injection of a liquid, I'm not sure which.
So, or an adjunct.
Or an adjunct, yes.
So sometimes a curettage doesn't work, and you may have to use an prosthetic, but by and large, you try and preserve bone, you try and preserve
Do you use high-speed burn?
Yeah, so curettage will involve using a curette and a high-speed burn. You want to go past the margin. So even in a benign condition, you have to plan your surgery quite carefully. Okay. Anyone else know an adjunct? Liquid nitrogen. What are the problems? This is a great exam question. Table adjuncts, pros, cons. So what's a pro and what's a con of liquid nitrogen?
Well, it can burn the area around, so it's difficult to get hold of. Not having used it myself.
Yeah, so if you haven't used it, I mean, I've never used it. I've seen presentations about it used, but it comes in a container which smokes, so there's some theatrics in the theatre. But it's not like you can just put in a jug and or a syringe and drip it in. It's very difficult, so it can spill, it can freeze your good tissue, and if you're working near a nerve, that's obviously a problem. And it's not readily available. It's dangerous also. If you spill it on your hand, it's not great. So that's why we don't use it. Anyone else? Another adjunct? What's a simple one? Hydroperoxide. Yeah, it's a bit naff. Yeah, people use it. Phenol. What's the problem with? What's the good and bad things about phenol? It's available. We can get it in our pharmacy.
I'm just trying, but phenol had a problem with this element of recurrence. I'm also sure.
That's not really due to the phenol. It's probably due to your curettage and burn, and maybe you left some behind. Phenol is a poison. Obviously, just like chemotherapy, which are intracellular poisons designed to kill cells, not just cancer cells. Like hair falls out, get the mucositis, etc. Phenol is meant to kill stuff, so it's a poison. And then how do you just put it in? You suck it out? Do you know anything about phenol? You're going to rinse it with alcohol afterwards. Anyone else for an adjunct? We use cement. Yeah. So GCT, many places around the world, most places probably use bone cement as an adjunct. Any idea why they do that?
It's a synthetic reaction that comes with it, so like bends the.
It's a great void filler. It's structural, and there's possibly a thermic effect.
And it's also, you can also very clearly, when you follow the patients and look for recurrence, it's very easy to see where's the demand and where's the new tube. Recurrence coming, if you do a bone transplant or which resorbs, then it's difficult to know what is the normal evolution of a bone transplant and what is tumor recurrence.
Absolutely.
And of course, the good thing is that the patient can have full weight bearing 1 hour after surgery.
Relatively inexpensive. You know, if you look at a large GCT, maybe you'll use 80 grams of bone cement, so it costs you roughly 3,000 Rand. Whereas if you had to use 80 cc's or something like ProDens, it's going to cost you 80,000 Rand. Like 20 cc's of ProDens is about 25,000 Rand. So that kind of synthetic bone graft, you can't give autograft, it's too big a scale. It's difficult. I use bone graft as an adjunct, and rightly or wrongly, I feel that they're young patients, and so I want biology, but it comes with a side effect of not being able to see if there's a recurrence. Puts pressure on your curettage. Bisphosphate, just as a side, bisphosphate into your bone graft or bone cement is an interesting thing. Some people are doing that. The local control of GCT. What's the other drug we use for GCT?
Denosumab.
You should know denosumab for your exam. It's very topical. Some benign issues aren't salvageable, and you have to use it in the prosthetic. Malignant surgery is very discuss that briefly. Let's move on. This is an interesting case where you use a Capella technique. This is not my case, but you can see it's a young child with open growth plates. There's a big bulk allograft there, which is irradiated, and that acts as the bun. And then vascularized fibula, you may be able to see some of those clips on around the mid aspect of that, the AP lateral, and those are the vascularized fibula. And it's stabilized with the plates until you get bony on-growth from the femur onto your biological construct. We don't do much cryotherapy, but you should know that it exists, and there's also radiofrequency ablation, especially for things like osteoid osteoma, where they drill a probe under CT guidance into the lesion. They they blast the probe with a frequency, which causes a thermic effect of varying sizes depending on which probe you use. Issues there are cost of the probe, and you don't get any specimen, and so you're not sure exactly what you're treating. Sometimes you have to repeat it. Okay, not for this. Not for this talk. These are just some examples. I think that was one of our dystophias. I don't know if it'll play. Okay, so in order to involve the back end of the room, we are going to do a few cases, and I want you to describe the X-rays, and then I would like the front row to say what they've missed. That's when Marit's here. So now, any questions at this to this point? I think. Know why the screen is not sharing. Okay. Someone from the back who I don't recognize. Chap with the glasses, I haven't met you. What's your name? I'm afraid it's you.
Dane.
Dane, okay. Dane, I appreciate this may be a tough one. So actually it doesn't project well, so I'm going to give you a slightly easier one. You see that?
I see it.
Sure. Just do the lights. Okay, start.
Yes, we have a X-ray of pelvis and slightly mature patient.
Yeah.
The lesion noticed in the right proximal femur, in the intertrochanteric region. It is a poorly defined, ill-defined lesion, not easy to appreciate where it ends and begins. It's involving the metaphysis of the femur. Can't really see if it's extending to that point, or up into the neck. I don't see it extending to the neck or the head of the femur. It seems to have reached the cortex, so it's not. Yeah, it's reached the cortex. There's periosteal changes, seen mostly around the greater trochanteric region. It's, I would say, mixed in terms of lytic and plastic nature. I mentioned periosteal reaction. The matrix itself, sort of ground glass. I don't see any obvious, other obvious changes in terms of the matrix. I don't see any calcification. And then soft tissues. There does seem to be some involvement of the soft tissues. Again, I don't think it's not very clear. Struggling to see anything further.
Okay. It was a very good attempt. What system do you use, or do you not use a system?
Is that you might expect MEC pH. Otherwise, there's anything questions.
Yeah, I think have a system that you use. I personally don't like an anagram or whatever it's called, because you start to panic about remembering the anagram rather than describing an X-ray. I just use a fairly simple out to in or in to out method, and just just discuss those areas as we get to them. So I will do some soft tissue, and I'd say that there is a soft tissue component, and then periosteum, and then bone, and then matrix, which covered everything. And just try to prevent yourself from getting into a circuitous pattern of just talking and saying the same thing over and over again, because then the examiner starts to either wake up or get bored, and neither of those things are very good. So I think you've covered everything, and this is a good example, and I hope everyone here appreciates what an indistinct margin is. Do you get that? I've probably got I already got that quite late in learning about these things, but the point is you can't see where the normal bone begins and where the lesion begins or ends. And that is very, very suggestive of a malignant process. So if you've got a lytic lesion with an indistinct margin, that's a problem. Okay. And then when you're describing matrix, just a few pointers. So lytic, good one. Blastic is a good one. Calcification and blastic is, for me, very similar, because they're essentially the same thing in terms of the blastic process producing osteoid, which then gets calcified. And so they are sort of similar things. But if you want to talk about calcification in something like a chondrosarcoma or a chondroid lesion, then that's different, because you can talk about the stippling or the rings and arcs or the popcorn. You're describing that particular type of calcification, where in this one you could describe it as cloud-like or woolly. It's still calcification, but it's blastic color. Hope you get that point as well. Periosteal reaction. What's a Codman's triangle?
The triangle forming where the periosteum left up is rapid growth underneath it, and causes rapid growth underneath the periosteum, which is off. So you see that periosteal reaction, same as with the sunbird region, you get calcification of Schwartz fibers, just meaning that there's a rapid growing process.
Yeah, so as Judy said, it's a pushing growth, so it pushes the periosteum off, which is actually a very thick structure. And if you go into different types of margins, and even a 1 millimeter periosteal margin accounts for a large amount of, or large margin of fat, which is not a good order. But the Codman's triangle is the bone trying to stop this process. So it's actually normal bone forming. Sunray spicules or sunburst, those are Sharpley's fibers. Sharpley's fibers attach the periosteum to the bone, and as it gets lifted off, they get calcified during that appearance. If you can see or not, you might have mentioned that there could be a fracture there of the cortex. I think it is extending up into the neck, but otherwise, that's pretty much covered. Once you've covered that inside out, outside in, stop and then try and move on to something that you want to talk about rather than you just want to tell the examiner that you've got a problem here, and then you can talk about differentials, which will either be neoplastic, infective, or other, like metabolic. And then you just work down on that tree. So neoplastic will be benign and malignant. Benign will be active aggressive, malignant will be malignant. And have something to say, just have one or two little answers. It's going to be something obvious. They're not going to ask you something strange. Let's do one more.
I want to
What was the diagnosis? Have you said that?
Yeah, so do you want to go and give me a differential for that?
How old is she?
She is, what did I show you? This one.
I think she's like 14 or 15.
Yeah, that's correct. So she's 15.
Okay.
Then any, so go through, is this neoplastic, infective, or metabolic?
I would say it's neoplastic and I would say it's malignant.
And it's malignant. So in a 15-year-old and a proximal female, you've got a malignant bone lesion. What are your top two guesses? Top one guesses. That's what it was. So if you just break it down into the parts, it becomes easier rather than staring like a deer in headlights and looking at trying to think of the spot diagnosis, which a lot of the time is impossible. Okay, someone else at the back. Back row. The gentleman there, what's your name? Oh, sorry.
So you're presented with the AP X-ray of tibia figure. Obvious pathology here, you can see well the proximal fibula is a wide expansile lesion. Starting from outside, there's soft tissue swelling or enhancement. Coming inside, there's a rheostat reaction, as well as cortical break on the lateral posterior aspect of the fibula. The lesion is quite expansile.
You said that already.
Sorry, yeah. Matrix.
The fine
Matrix looks like it's quite lytic. Zooming, slightly zooming. Yeah, thanks. Yeah, so the lesion is lytic. Expansile.
Yeah, so
it's described. Coming to the tibia, proximal tibia. Looks like so it's extending past the joint line.
So when the good tip is when you repeat words or have long pauses, then probably finish what you've got to say, and then so move on to differential.
So differential here is you have plastic, and in the plastic you have probably more tumors. It's setting out the worried about so I'll start with the benign aggressive setup. I'm worried about ABC or giant cell tumors setup. And then benign lesions, I'll be worried about.
That's fine. And then you'll probably only get one or two, maybe three. And then in your mind, when you start to panic, then move on to how you're going to investigate it and treat it. So keep talking. Anyone like to comment on the appearance? How would you describe that appearance of this expansile? And can everyone see that there is a narrow, although this is an aggressive lytic lesion, In contrast to the other one, where there's a very indistinct margin that you can't really see. You can sort of see where this begins and ends. Okay. Not a great example because it's so expansile, but you can see that difference. You can see these areas which are slightly better defined. So is there an extra? Yeah?
So is that when you say it's a narrow zone of transition, that's in a wide zone of transition is when you use it, when it's the hazy, you can't, it's indistinct.
Yeah, so the borders, you're not sure where the borders are.
So this is a narrow zone.
So, yeah, and it's not the best example.
In this case, you can see it's sort of expanding the bone, whereas in the other case, the architecture of the proximal femur was intact, but it grew out of the bone. Here, it's sort of just expanding and destroying as it grows, it's destroying the proximal fibula. But it hasn't really grown out of the fibula.
Yeah. So, I mean, if you see that border, that's the border between normal fibula and lesion is small. You can see where one begins and the other ends.
And it's also epiphyseal, which is hard to see on a fibula.
Would you call this loculate? Just loculate?
You
Was
could,
more the soap.
so this is a classic example of a soap bubble, and that's that bubble bath that you mix for your kids and yeah. So this is a soap bubble appearance, which is quite classic for a GCT. If the examiner asks you, well, okay, of your ABC or GCT, which one? It is useful, as Henrik said, is to say where it is in the bone, which Dane said. He said it was metaphysis and that kind of thing. You said proximal fibula, that's important. So what are the 3 benign conditions that will occur, not only, but what are the 3 most common benign conditions that occur in the epiphysis? So we mentioned 2 of them. So GCT,
The antibodies was to
often a chondroblast. So,
Last time, sorry, maybe this is ridiculous, but a GCT occurs where the epiphysis was, but the physis is closed.
sure.
So if it's open, I'm not going to say GCT. Apparently, I thought you can't get a GCT in an open physis.
I'm not sure about
I think
but
you very seldom you see GCT under 15.
Okay.
And the same
So it's
time,
really only
if you have a 20-year-old and the radiologist says aneurysmal bone cyst, he probably doesn't know what he's talking about because it's usually doesn't have to be, but usually.
No, that's the hard thing about these things is that most of them fit into the box, but
And then last question, often they talk about ABC forming in a GCT versus ABC alone. I don't really understand that concept.
so that will most likely, you'll see that in an MRI, where you see fluid levels, which are almost pathognomonic of an ABC, but there will be other areas that are more GCT-like. And even in surgery, you'll get to the surgery, you'll find this gritty yellow-brown substance, which is not in an ABC, but you'll also find oculated blood.
Okay, so there's no prognostic thing I can determine the primary ABC versus the secondary ABC that's formed in the GCT. There's no difference in management.
You will still manage it like a giant
GCT, yeah.
Thing is, if this patient was 65 and not 30, which I think she is, you would think, but then what do you think?
At 65.
Yeah. Well, simply differential diagnosis.
Maybe a chondrosarcoma?
No.
No. So I know GCTs, they can develop occasionally on osteosarcoma, very rare.
You can find guys with a 60-year-old, but it's quite rare.
Yeah.
But as soon as you go up in age, then primary bone tumor becomes less common. Right?
Yeah, I just said chondrosarcoma because it's more on the elderly rather than
But if it's
osteosarcoma.
it's not, primary bone tumors are uncommon. So what's more common?
It's not typically multiple plasma.
Myeloma, plasmacytoma can really look like this. And also
Would it expand the bone like that?
kidney cancer metastasis.
Does it expand the bone?
Yes, yes.
You know, the renal cell carcinoma.
And renal cell carcinoma.
If this was in the distal femur, what would you consider in a, and let's say it was in a 17-year-old?
Telangiectatic osteosarcoma.
Yeah.
So that's
So if you ever see an ABC and it's behaving quite aggressively and it's in the distal femur and the right age group, you must consider telangiectatic osteosarcoma.
that was my next question. So they talked about some of the articles talk about the some of them just talk about your differential diagnosis for a sub bubble or a, and this doesn't look like the osteosarcoma, but I'll put it last on my list, but this clear cut, almost clear cut GCT. But between this, they say it's ABC and telangiectatic, and there's another one.
You can get a giant cell rich osteosarcoma, those are the less likely variants. What about an ABC is important in the biopsy? And likewise, what is the importance of a telangiectatic osteosarcoma in the biopsy? Because if you put your needle in, what's going to happen? Blood's just going to. And if you pour the blood into a specimen jar, the pathologist is going to say it's non-diagnostic. Try again.
I think they took off a small lining, membrane lining that is supposed to actually take the biopsy.
Correct.
If you don't get that, then you won't get anything until it's restricted.
Sounds good. So in an ABC, you need to curate the lining, which is a grayish type membrane. And then in telangiectatic osteosarcoma, when it's outgrown, it's sort of blood supply with bled in the middle, necrotic in the middle, you need to take them all reactive. So what, anyone for a bonus question? What is the treatment of one? Okay, two bonus questions. Who classified GCT? One of them. And what would be your treatment of this? Michael, you can't answer. What's that classification? Because GCT, I think, is a fantastic question, a long question in the exam. You don't get long questions anymore, which is a shame, but I'd still break it down to the short answer stuff.
Get long shoulder questions. You have to see an exam.
But apparently classified.
Twice. Component,
Yeah.
Okay. I mean, GCT is such a good question, you can ask everything on it.
So GCT is the one that you can do a curettage and they do well with the adjuvants. You can use so you can use a high speed burst means.
Would you do that in this case?
No.
Why not?
I don't think there's a cortex. You're going to open it up and you're just going to curettage it, and you're going to find there's no cortex to work with. It doesn't look like.
What's the problem with that? Do you need a cortex in your fibula? Really?
Are they worried about the nerve running there on the top?
No. Find the nerve.
I don't know, you can just, instead of just curettage body, you can't resect it. I mean, you don't need that body.
Okay, what's going to be the problem with the resection?
Margins, difficult if your margins are
What's the
recurrent.
problem with recurrence? What's the recurrence rate of a GCT? This is a Campinachi 3. And it's extended as a soft tissue. 50%. Depends what you, there's a lot of variation in the literature, but it's high, very high. So what can you do here to reduce your rate of recurrence or your chance of recurrence?
You give denosumab?
Yeah. Okay, well, there you are. So it's controversial how much, how long, et cetera. But you give denosumab, so it forms this fantastic rind around the tumor, lessens your chance of intraoperative bleeding if you're going to do a curettage, and facilitates surgery. So instead of this soft bunch of grapes that's going to fall everywhere, and you're going to get recurrence, and then you're going to have to revise the previously operated area, you get this nice rind and you can resect it on block.
As far as I know, so the news about it, usually when it came out, I don't know how many years ago it was, we got it as a silver bullet of GCT management, and nowadays even the other day when we did a GCT, Prof said it's not that.
Yeah, so unfortunately, it wasn't as effective as we'd hoped because although it eliminates the giant cells histologically from the tumor, it leaves the mononuclear stromal cells behind, which is actually the driving agent in forming giant cells and driving the process on. So you give the denosumab, the tumor shrinks, it forms a rind, patient symptoms go away, you stop the denosumab and the thing comes back and can come back worse, and then has the potential to become an osteosarcoma. And then, I mean, this is why GCT is a great question, because you can ask about denosumab, its side effects. So its side effect profile is very similar to bisphosphonates. And its management is similar because you give a denosumab every day. What's the frequency of giving denosumab, etc. But let's say you had a GCT of your odontoid peg, denosumab is still going to be your. It still has its uses, but you have to really define what those are and understand them. So our use here for denosumab, and we give it, it's about 5,000 Rand a month. We give it once a month for 3 months because that's what we're allowed to do. And it forms a rind and it facilitates surgery in Kaplan G3s. Others will probably curettage and cement or bone marrow. Okay, this is very similar to the first one we saw, except it's a 52-year-old man. We see this wide zone of transition, soft tissue component. What's your differential going to be? Yeah.
Multiple
Okay, and how are you going to manage it?
You get the diagnosis first.
Because it could be an osteosarcoma. It's got a lot of the features of an osteosarcoma. Very similar to that first case we discussed.
Systemic staging, including our biopsy.
Yeah. Find your unknown, so it's an unknown primary if it's metastatic. So biopsy, it'll come back as something like an adenocarcinoma, which just helps because it's not a primary sarcoma, but it doesn't narrow it down that much. So then you're going to need to find your primary, then you need to treat it. So how are you going to treat this one? It's an adenocarcinoma, it's a lung metastasis.
I'd like to chat to the oncologist about his life expectancy. Okay. But I think just on its merits.
Did you have to chat to the oncologist about life expectancy?
Not with this, you're going to need.
What are they going to say?
Good. Mine's 2 years.
Speak to some oncology registrars who suck some garbage out of stuff.
They're always too optimistic.
I think this means, yeah, in that case, chemodality nail, expanding the full length of the
Yeah, I think there's enough bone in the head, and then what are you going to do after?
Radiation.
Yeah. And what could you do at the time?
Cement and venting. Venting is still
So
controversial.
things you, so I think Nando is always pathological, or is fractured. But cementing that area can often help with the pain scores. Maybe not in this guy, he looks like he's got an intact medial cortex, but certainly if it's fractured or there's a much greater zone, it's.
Yeah, we can cement it because it looked good.
Yeah, so intraoperatively you get great bone and it can be stable in the radiotherapy. So what in metastatic disease is sort of new on the market and people who are playing this? What's the problem with a nail and giving radiation?
Fracture healing.
Yeah. So only 40%, about 40% can heal with radiation, but The radiation is going to bounce off the nail. So you're not going to really get a great dose to the whole area. So how do you combat that?
Other pre-op or needs or something to the areas.
So carbon fiber. People are making these fancy nails or carbon fiber nails. Used to have their prob, also a good question. They used to be only very straight, so you couldn't put them in a bowed femur. I think they're now producing with a bow on them. They're all the rage, I think, in the UK with metastatic disease.
But if this wasn't fractured, but if it was fractured, would you still put it in a nail?
I think so, yeah. That's what we generally do, just from.
I don't think there's very few who would really recommend a nail because it doesn't provide enough stability to make the patient, let the patient ambulate without pain immediately. You can never tell a cancer patient, well, you can have full weight bearing for 6 weeks because they might be dead in 5 weeks, so it's pretty useless. And it's not going to be better after a month after surgery. The best ability is just when you're closing the wound. So what is an alternative?
Proximal femur replacement.
And what do you need? You need a big fancy prosthesis, or can you use a conventional?
I think in most cases conventional, not having put in many mega prostheses myself.
Well, I think Henrik's talking about not a mega, but
You don't really
But
need
it's
to
just
put in a
long
mega.
term.
Last step.
Past fracture site 2 times the width of the
Exactly.
cortex cemented.
Even with the lateral cortex.
Yeah, that doesn't matter. Just you go down and take a 200 millimeter stem instead of a normal 15.
that's fairly cheap as well.
And exactly, and you always do, you don't have to worry about age, even if there's metastatic disease and the patient is 22 years old, you can still do a hemiprosthesis because they won't live so long that they'll have a problem on the aesthetic side. And the prosthesis has its complications, but it really makes the patient pain-free in a way that the nail doesn't.
There was a paper that asked sort of general orthopedic surgeons and then tumor surgeons what they'd use, and there's a definite preference to use what you know.
Because what happens if the patient actually lives for 6 or 9 months, which is uncommon that they do, then because the fracture won't heal, the nail will break. Because prostheses are made to bear weight for 10 or 20 years. The nail is only made to bear to hold weight for maybe half a year or a year. Then the bone has to heal, otherwise the nail will break.
Yeah. So think about if this was you or your family.
So you have to look a little bit on the prognostics of the patient.
Yeah, aggressive small cell sarcoma, carcinoma, lung carcinoma. So his prognosis is like 3 to 6
And it wasn't
months.
broken, which is also.
He was broken, yeah. So 3 to 6 months, and then unfortunately he spent a month of his remaining time waiting for his.
So while Chris is answering this out, in my head I was thinking, so we have wrong if in the exam I answered it straight for proximal femur. Instead of that.
No, you would not be wrong at all, but you would need to anticipate the next question, which is going to be in our situation with resource constriction. How much does a proximal femur cost? And is the get into this horrible debate about what is ethical and all that kind of thing. But no, Keith Hosking would undoubtedly put in a proximal femur for this patient because he knows that the patient can get up the next day, mobilize on it, fully weight bearing, go home in 3 days' time, and enjoy the rest of what life remains. So no, you're not wrong, but you need to have an answer to say why you're doing it. So a lot of people would say around the trochanteric area, if you've got a large lytic net, that you probably should do a proximal femur, or as non-cemented stem.
This guy took a week to mobilize even after a nail, and there's no fraction. So there's obviously a pain generator there that you might take out if you do a longer section of the proximal femur. Then you take away the substance P and the prostaglandin pain generator in that lesion.
So not only that, I mean, you've got pain because his bone is still weak. And you've put really an inferior device in there to allow him to mobilize on that full weight. So no, you definitely wouldn't be wrong at all. And especially if the lesion goes up the neck into the head and you've got a few centimeters of bone and you put the, imagine you've got a fracture, you now get an intertan that cuts out. You spend 6 to 8 weeks working on this cutout thing. If you're in private practice now, your medical aids all used up, and you need to go in for another procedure. You're in hospital the whole time. So your comment on the proximal femur is not wrong, but you need to say, and then have an answer, because they all think it costs hundreds of thousands of rand. The proximal femur in state here costs 60 grand. And it's quite a lot of money, much more than a nail, but it's not the end of the world. So if you put in an 18 grand nail that fails, you've wasted X amount of hospital days, X amount of theatre time. Now you've got to come back, put another prosthesis in. Are you really saving money?
I'll go there.
But just have an answer. You can say, no, I mean, absolutely, I could do a nail, but these are the reasons why I wouldn't.
So you're in the last operation first.
Correct. It's 9:15. Do you want to discuss oncology, or have you had enough?
Okay. I see guys in the back row.
Yeah, they're all keeping quiet. We'll just quickly go through it, because
Because it's not like zero.
But the tumor doesn't.
Sure, Brandis.
That's it?
Sure, Brandis. You see other people.
you can stand up, get it, grab another beer. So, oncology, medical oncology, really 3 main things: chemotherapy, radiation treatment, things like denosumab, bisphosphonates. So the main thing about cancer that you must always keep in mind of is that it's uncontrolled cellular growth at a DNA level. Okay? So your normal controls are not there. You've got this cancer that's going spastic, and you need to control it. Okay, skip that because we've covered that already. So, firstly, chemotherapy, it's responsible for improving 5-year survival. Remember, neoadjuvant, chemo before surgery, adjuvant chemo after surgery. Okay, reduces the tumor bulk, disease, facilitates surgery, gives you prognostic value. Okay. Don't forget, it can be given as a palliation treatment as well. So if you've got widespread metastatic disease, you're in pain, not feeling great, chemo can make your last weeks, months better. So it can be given as palliation, usually at a lesser dose and fewer agents. And the thing about chemotherapy is a little bit about TD, a little bit like TD, when you give 4 drugs, because each drug that acts synergistically and increases your kill rate, as is the same with chemotherapy. Whenever you think of chemotherapy, remember there are drugs that kill cells. They don't just kill cancer cells, as amazing as that would be. They kill all cells, mainly rapidly dividing cells. Okay? And different drugs act in different ways, of course. So dose-independent drugs, so if you can give a set dose, it has its maximum kill rate, are drugs that affect the cell in one phase, okay? So you think about it, how chemotherapy works, as the DNA is replicating and unwinds, the chemotherapy drug goes and attaches to each strand at various points, preventing it from being able to join again. So then the cell is essentially dysfunctional and dies. That's how DNA works, okay? And that's apoptosis. The other major class of chemotherapy drugs are those that are dose dependent. So you give more of the drug, you'll get a higher kill rate, and they act on all phases of the cell cycle. Obviously, you want to give people are moving towards, this is a good point to remember, higher doses of drugs for shorter intervals. Okay. But you play a very dangerous game because chemotherapy can kill the patient. I've had patients that have died from chemotherapy. So you want to give them a lot, but not too much, because they can go into a white cell crisis where they've got no white cells, they get an infection, can't fight infection, and die. Don't remember this. And then the other point to remember is because they don't only affect cancer cells, they affect all rapidly dividing cells. That's where the side effects come. Your hair is rapidly dividing, your nails are rapidly dividing, your mucous membranes of your gut are rapidly dividing. So you can work out what the side effects are going to be. Hair loss, mucositis, diarrhea, all those problems. Bone marrow, so your bone marrow is rapidly dividing, the bone marrow suppression.
And sterility.
Yes. So we don't see this in our practice because we biopsy the patient, we prove that it's a sarcoma, and we send the patient to an oncologist. And they do the workup, they do the hearing tests, they do the heart, the radionuclear tests on the heart to get a baseline for the cardiotoxic drugs that are going to affect them. Then they chat to these poor teenagers about sperm banking and egg banking, all this kind of thing, which is a really tough conversation to have with them. But it's a reality, because once you survive your cancer, you've got the rest of your life to live, and you might still want kids. So bone marrow, we get myelosuppression. So this is often why we got to 11 to 22% rate of infection after cancer surgery, because you've got cancer, so you're immunosuppressed, you've been given chemotherapy, which knocks your bone marrow, and you're going to have a big, long operation, and the cards are stacked against you. We use cell saver to try and minimize donor blood, because that's bad. I'll just summarize it like that. And we give GCSF, which is it stimulates the bone marrow to wake up and to produce white cells and red blood cells and platelets. Okay, it's called Neuprogen. And then, just to say that most of our infections, unfortunately, come from our own bacteria on our skin and GI. Hair loss. When you lose your hair and it grows back after chemotherapy, it can look different. Called chemo curls, different colors, different styles, etc. You get chemo brain, much like pregnancy brain. I'm not sure if you're allowed to say that, but cognitive impairment, because your brain also gets affected. Mucositis is a very bad one. It's horrific to see the patients who are on chemotherapy come in with cold sores, with horrible, painful sores in their mouth. This is also the stuff we don't see, the oncologists see. It's obviously very nauseating. If anyone here suffers from bad seasickness, this is like seasickness on steroids, and I suffer from it, and all I want to do is die at the bottom of the boat. So imagine going back for cycle after cycle of chemotherapy. It must be very traumatic. Mostly weight loss, some weight gain because they're overeating to try and prevent weight loss. And then sometimes we give them steroids to help with the side effects, and that causes them to gain weight. These are some of the sort of lesser side effects, infertility being one, and that's why we do cryo preservation. Peripheral neuropathy, so this is important because for us, why am I mentioning it? Before the operation, we've got to see what our nerves and blood vessels are doing, in case we prang one of them during operation, and we want to know whether it was there before or not. Unfortunately, it's often irreversible, and it can affect both sensation and motor function. Tumor lysis syndrome, this is the one that kills patients often. Cancers with a high white cell count, leukemia, lymphoma. These are cancers that respond very well to chemotherapy. So you get a rapid breakdown of the cells, rapid release of all the things inside cells. The main one is potassium, which can cause a cardiac arrhythmia and death. And other things we often test for, although maybe unwittingly, is the calcium and the phosphate. Those can be high as well. The main three that I would, actually four, is cardiotoxicities, and we need to know about that. This would be my question. If I just had a question on medical oncology, it would be about side effects of chemo and how they relate to an orthopedic surgeon. Most of the time they don't, but when you've had neoadjuvant and you're going for surgery, those of you who've worked in a firm and worked with Alma, I mean, she's a great anesthetist, but can be trying at times, and she wants to know what the cardiac echo was, because it affects her. So you should know about it. So DNA damage from the chemotherapy can cause a cardiomyopathy. Liver function, so we do or should be doing LFTs prior to surgery. Nephrotoxicity and ototoxicity. The platinum-based ones, or the alkalining agents, which I skipped through, can cause this, and they are part of the osteosarcoma. Okay, we've mentioned GCSF before, and we give supportive products when hemoglobins are low. So leucovorin is a little bit like GCSF in that it is given to patients who are on methotrexate. Okay. It really just helps bone marrow cells and the mucosal cells regenerate. I think you should know about methotrexate because it relates to osteosarcoma. It's not in all of the protocols. Some centers are more aggressive than others. And here, our protocol with methotrexate is usually for children, so therefore at Red Cross Hospital, and it's usually reserved for very aggressive tumors that are not responsive to the standard drugs. We usually give it adjuvantly after surgery when we see that there is a poor necrosis rate, and we want to try and give the child best chance. So we add high dose methotrexate. So when do you start, when you operate after chemotherapy? That's also important one for us to know. Usually it's between 3 and 6 weeks, but you should do an FPC to check what the white cells are, check the hemoglobin. You should not operate if the white cells are less than 1. Okay. We'd like them to be higher than that, but we don't want too much of a delay. What neoadjuvant chemotherapy gives us is a window in which to do the surgery. But really, you want to continue the chemotherapy as soon as possible. So we don't want big delays between neoadjuvant and adjuvant chemo. But you also don't want infections, and you want your patient to survive the operation. So usually we give 3 cycles. Okay. Sometimes we give more, up to 5. If there is, for example, a problem with surgery, sometimes you've had to delay if the patient's coming from PE. We don't have a theatre list here, etc. So we can give an extra cycle. And then and then afterwards, as I mentioned, with high-dose methotrexate, we can add that if the necrosis is poor. We've mentioned about my approach to necrosis. It's 90 and above, 90 and below. You'll hear some studies report different numbers. but I would keep it simple, okay? And then just realize what it's talking about. It's the Huvos's osteonecrosis in osteosarcomas. I wouldn't worry about that. Is there any questions on chemo? So basically, you just got to know how chemo works, some of the side effects, how they relate to you, and how to fix them, okay?
So can I just ask, if you was staging done at the time of resection, does that then you want to know your percentage at that stage to prognosticate and potentially change treatment in terms of the adjuvant?
So for us, look at again, it's an MDT discussion, but and at the MDT it was okay. This young man's had a surgery, had his chemo, had a surgery. The margins, we discussed those, then we discussed what the necrosis rate is, and then we discussed how he tolerated neoadjuvant treatment. What would he tolerate adjuvantly? Would he tolerate high-dose methotrexate? Some patients, we've had a few who've had their first dose of chemo, it's almost killed them. So then we go straight to surgery, and we just hope we get a good margin. There's no metastatic disease. And then we sometimes don't give adjuvant chemo because the risk is too high for the patient. Okay, so what is radiotherapy, or what is radiation? It's really just high-dose X-rays. So it's ionizing radiation directed at the tumor in order to achieve the same thing as chemotherapy. As the cell is dividing, the radiation disrupts the process of DNA replication, and the cell dies by apoptosis. So, does anyone know how radiation is given? So, what will the oncologist, the radio-oncologist do? Will they just give 60 gray to a soft tissue sarcoma?
And map out the tumors based on imaging and plan how much they want to try and cover as much where their beams are going.
Yeah.
Kind of.
So they draw the tumor volume, then they give themselves a margin of error for the patient moving, and then they give themselves an extra margin over that. So that's an important point to understand about radiation. Patient gets positioned very carefully in a very specific position because the gantry of the X-ray machine needs to know where the tumor is in relation to itself. So you can tell the computer where the tumor is by mapping it out, by the planning that they do. So they do a planning CT scan where they can see the tumor. They do all this mapping. Patient gets positioned on a specific part of the table in a specific position. So they'll often have molds. If you're radiating the brain, you'll get clamped into something so that you don't move. If you move and the radiation goes, you could miss the tumor completely. Okay, so that's why you've got different margins. What I'm trying to get to is, so you work out a set dose, and we've discussed for soft tissue sarcoma, given adjuvantly, it's about 60 gray. Neoadjuvantly, which is where we're moving towards, it's given at 40. What would happen if you gave 40 gray to the patient? Do you give all 40?
There's the way giving it pulses.
What are those pulses called? Is it pulses in the same setting or different settings?
I think it's the same setting but different doses. I wasn't sure how they do it.
So metastatic disease might be just one setting and they give a 20 gray. But if you gave 60 gray to a patient on one setting, whether you pulsed it or not, you'd probably burn a hole in it. So it's really ionizing stuff. It's like Chernobyl. So they give it in fractions. They divide the fractions up. The first reason is so you minimize the side effects. The other reason is that all your cancer cells are not going to divide at the same time. So you give radiation at one time, you're going to zap a proportion of them because they are in that phase, cell phase, where the radiation is going to work. You bring them back another day, the other bunch of cells is going to be dividing, so you get those cells. That's the other rationale behind radiation therapy.
60 would go 2020, say, over 3 days, 2020, or?
No, so they give them much smaller fractions over a much longer period of time. And it depends on the tumor, it depends on the size of the tumor and what type of, let's see if I can find the slide where, is it on here? I've got a slide somewhere where it shows you all the different, there are many, many different types of radiation. Okay. You don't need to really know that. Oh, there we go. I list these for interest sake, okay, but really it's all very confusing. So it really depends on the tumor, what type of radiation you're giving, and the patient. So, but you don't need to. Just know that they're different types, and they're given a fraction. And I think what you should know is the differences between neoadjuvant radiation and adjuvant radiation. In the past, you would get a soft tissue sarcoma, make the diagnosis, cut it out, leave clips in the bed for the radio oncologist, and then they would give 60 gray to the whole surgical area. But that was problematic because you get much higher side effects, which mainly are skin issues and fibrosis and stiffening. So if it was around the knee, you'd get a very stiff, leathery skin with a stiff joint. Okay? It was horrible. So now they want to give less radiation to a smaller area and have the same effect. So that's where neoadjuvants come in recent times. It's got its pros and cons. The neoadjuvant is good because the oncologist can see where the tumor is. Whereas once you've cut it out and you've got a big hole, they can't see anything. They can see post-surgical changes on the CT scan, and they just have to color in that whole area. And often they'll come to you and say, look, where did you go? What did you operate on? Where you know, how hard did you go? How deep did you go? Because they can't really tell. So they give a lot of radiation to a big area. With neoadjuvant, they can see the tumor, so they can target that. And they give less radiation, so you get fewer side effects. But the problem then falls to us because we operate on an radiated area of soft tissue. So we get wound complications, wound breakdown, infection, etc., etc. So for us, it's not great. It's better for the patient in the end, I'm not sure. That is a very topical subject. Okay, it's getting late, it's 9:30. So we've discussed this a little bit. So radiation can be used in processing of your autograft. We can give, so for prostate, things like that, you can give brachytherapy, which is small little pellets, irradiated pellets, which they shoot through these pipes that go through your prostate and give the radiation locally, or they can be placed in thin catheters at the time of surgery. So we've discussed this. So solid tumor, I haven't actually entered here the neoadjuvant stuff, but that would be about 40 gray. 80 gray is actually, I don't think anyone gives 80 gray anymore. It's quite 70. The 70 is probably your max. Usually it's around 60. Metastatic, it's about 20 gray as a single fraction. We've spoken about planning. Side effects are the obvious ones. So you're giving, it's like sunburn. So the patients often get a bad skin reaction that mimics sunburn. They can get some peeling of the skin, like redness, pain. Funny enough, they often get fatigued. They get tired either during or after their radiation. And then those are the early side effects, which you need to group, and then you can group them into the late side effects.
Well, is it painful?
It's not painful, no. No, I mean, it's a little bit, it's exactly like an X-ray. So
Then afterwards you get this done.
yeah, it's like a day or two afterwards, you start to get the early side effects, and then months down the line, you get the late. An important one of the late is the radiation-induced sarcomas. One other thing I want to mention here is this radiation-induced pathological fracture. You'll probably forget it, but keep it at the back of your mind. If a patient has had radiation to an area for a soft tissue sarcoma, and there's a bone there, most commonly the proximal femur, that causes osteonecrosis of the proximal femur. You get very much a fatigue, stress type fracture. And no matter what you do to it, it won't heal. You can nail it, the nail will break. You can DHS it, the nail will break. It's because the bone is dead, so the fracture doesn't heal. Okay. And a while ago, actually, you can look out for the next SOJ. We published a short series where the patient would have between 2 and 3 operations before coming to tumor surgery. And they would have either a nail that breaks, a repeat nail, a DHS, or you try something else, but they all fail. So really just need to heal the steel of the situation. The late side effects are mainly fibrosis, joint contracture, which we've spoken about. Those are the pros and cons, which we've also spoken about. Great question. One thing I didn't mention there, I guess, was prognosis. So if you give your radiation post-op, you're not able to see how sensitive the tumor was. So if you give it neoadjuvantly, you can assess necrosis much like a bone sarcoma. Okay, we won't speak about those, that's right. Any questions?